From Sarasota Memorial and the Deb Kavanaugh Multimedia Studio, this is HealthCast, a healthy dose of information from experts you can trust.
Hi, everybody. Welcome to HealthCast. I'm Allison Gottermeyer. Thank you so much for joining us today as we talk about specialized cancer treatment and the focus on multidisciplinary care at the Brian D. Jellison Cancer Institute at Sarasota Memorial. Our guest today is Dr. Richard Brown, an oncologist and the Chief Medical Director for the Cancer Institute here at Sarasota Memorial. Dr. Brown, thanks for being with us today.
Thank you for having me.
So the Brian D. Jellison Cancer Institute brought comprehensive cancer care to Sarasota under one umbrella. Can you talk about the vision for this and how it kind of impacted cancer care locally?
Cancer care is difficult. Cancer is a difficult disease. The symptoms of the disease are it's tough. It's tough on the family. It's tough on the patients. The treatment's difficult. Again, everything about it is hard. And so we're trying to make it as easy as possible. And certainly what we had prior to Jellison is people traveling all over town or having to leave town. And we think that that's not right. That's not the way to deliver care. And we think that we could do a better job right here in our own community. So the way to do that is you get everyone together as a group. You say, this is the way we're going to practice. Put it under one roof as much as you can. So you make it easy on the patient, you make it easy on the family, and you get a well-coordinated, patient-friendly experience where we did not have that in the past.
As an oncologist who's been in the area for quite some time, now that we have this umbrella, can you talk about what it's been like watching your patients be able to utilize all the services sort of under one proverbial roof?
Well, it's certainly, they're thankful that that's, the case because, again, it was hard. And a lot of people honestly felt that they had to leave town to get the care that they wanted, deserved. And now they don't have to do that at all. I mean, now with the physicians we're bringing in, with the coordination of care that we're having, and eventually when the pavilion opens up and we'll be able to have everyone just in one place so that they could drive in, see all their physicians in one place that they need to see to get their care, that will make it a lot easier on everyone involved.
I know most people have been personally touched by cancer in some way, whether it's a friend, a relative, a neighbor, themselves. But for those who maybe haven't been touched as closely, we're talking about coordination of a lot more than one doctor, one oncologist or something like that.
Yeah, correct. I mean, I say that the days of Marcus Welby are long gone, and that cancer care has become very, very, very complex. It was always required multiple people to communicate, but now it's really subspecialized, and you need ancillary care and supportive care in order to appropriately take care of patients. So you're dealing with lots of people, navigators, nutrition people, speech therapists, genetic counselors, as well as all the physicians. It's not just medical oncologists, radiation oncologists, and surgeons, but also, there are GI doctors, pulmonary doctors, and we all need to be on the same page in terms of taking care of these patients.
That brings us to the Cancer Institute's multidisciplinary care conferences. First, can you explain what that is?
So tumor boards have existed for years, but again, it was simple. When I first started here back in, a long time ago, there were just basically 3 or 4 people in a room, and we discuss a case or two, and that's it. Now we have 30 people in a room or on WebEx. The only possible benefit to COVID, from my standpoint, was that we branched out. So now we actually have our conferences on WebEx, so we could actually involve physicians who may not be able to get necessarily to campus, but want to participate so that their patients benefit from discussion. So what a tumor board is a physician who identifies a patient as being appropriate for discussion, which are usually patients that require multimodality treatment or really, really complex care, and they want to discuss that individual with their colleagues, surgeons, for the other medical oncologists, radiation therapists, so that they get the very best care. So we have everyone in the room or on, WebEx, and we have pathology there, radiology, the supportive care people, from genetic counseling to navigation, and basically that physician presents the case, saying this is who this person is, not by name, of course, but by, there's a 67-year-old person that has X, and telling us somewhat about the patient. And we look at the radiographs, we look at the pathology, and then we discuss what is the best care for that individual, including, are there any clinical trials that we need to do? What else do we need to do in terms of supporting that patient with the ancillary individuals that are in the room? And then we reach a conclusion as to, all right, this is what we should do, and make that recommendation.
Are there different tumor boards that exist for different types of cancer?
Yes. Well, again, when we started out a long time ago, there was one tumor board once a week. Now, Mondays, we have a neurotumor board. On Tuesday, we actually have two tumor boards, one which is breast cancer only, and one which is predominantly lung cancer. On Wednesdays, we alternate GYN malignancies and GU, bladder cancer, prostate cancer, kidney cancer. Thursdays, we do head and neck cancer and thyroid cancer. And every Friday, we have a GI tumor board, which covers everything from esophageal carcinoma to rectal cancer.
And it seems pretty obvious, but how important is it to have all of those different modalities, all those different physicians that you talked about in one space, agreeing on the right treatment or course of treatment for that patient?
Well, if I was a patient, that's what I would want to have happen, because you're not getting a second opinion, a third opinion. You're getting 30 opinions on what is the best way of dealing with your particular problem. So, and again, it's not just that there's one way of doing it. There's lots of ways of doing it, but taking into account the individual patient's, and also their experience. What does the patient want? So we take into account, we're hearing, what does this patient want us to do in terms of how they want us to help? But some people, say, I don't want to have chemotherapy. I don't want to have radiation therapy. But we take that into account. We come up with a recommendation for that specific person that is going to try to address their needs. And when you get 30 people agreeing this is the way we should go, it's a powerful thing.
And beyond the physicians discussing the treatment, having those physical therapists, speech therapists, navigators, whatever it is, the holistic approach to the patient, can you speak to the benefit of that for patients, making sure that their care is beyond just the surgery they need? Or
Well, yeah, so like I said, the navigators are there, and we're actually talking about what are the psychosocial needs of this patient? What are the barriers for this patient to getting care? And we try to address them. Are there issues in terms of the family that need to be addressed? Or there are issues in terms of their genetics? So this person may or may not have a genetic abnormality, which gives them greater risk of having not just this malignancy, but others, as well as what is the impact to their family? So we discussed that as well.
Where did the initial idea for these tumor boards come from?
And that's a good question. I mean, again, this is something that's been going on for quite some time. I think it usually came from, at least when I started out, where most physicians, that you run a case by a colleague. You run it in my office. We used to do this all the time. You want to really feel secure in the decision making, because obviously you have a human life that's you're making decisions about. You want to make sure you're making the best decision on their behalf. So you just expand that out to dealing with more physicians, more modalities, saying, I'm not just going to look at it from this point of view, but I'm going to have someone else look at it from another point of view. So I may say, well, we need to start this person on hormones, but the radiation therapist may say, well, wait a second, we could do this, and maybe this is a better outcome for the person. So you get a better decision making.
So let's talk a little bit about the process. Could you describe how a typical tumor board meeting runs?
Physicians identify patients. They call in the patient to our tumor registry, which runs very efficiently, and say, all right, I want to discuss this patient. These are the x-rays that I want to look at. This is the pathology that I want to look at. They organize it all. For certain tumor conferences are hybrid, meaning that we have people actually all in a room together and on WebEx. Others right now are just purely WebEx, but the pathologist shows it up on a screen, the pathology we want to look at, pointing out the relevant features. The radiologist is showing all the CAT scans, the MRIs, everything necessary for that patient. So we all have a clear understanding of the medical problems this patient's facing. And then you start a discussion. And the person, again, the physician whose patient it is, presents the patient, telling us the history and whatever relevant issues are with regards to that patient. And the navigators will also chime in saying, and this patient also has these issues that we have to address. The genetic counselor may say something else. Also, by the way, there are also pharmacists in these meetings that will address any pharmacologic issues. But we all sit there and we have a discussion. It could take anywhere from a few minutes to 20 minutes. And then we'll also discuss, well, is this person appropriate for clinical trials that we may have here? So, and it's pretty interesting and it's pretty intense at times.
Will a patient's case ever be revisited by a tumor board?
So, I tell patients that their life is not a snapshot, but it's a movie. So in anywhere from you could be diagnosed with breast cancer, and we're talking about adjuvant therapy to try and prevent it from coming back, but sometimes it does come back. So then we start talking about what do we do in that setting where it is a recurrent tumor, or we treated them with drug X, Y, or Z, or radiation therapy, and things aren't going the way we want them to. Now what do we do? Or in the case of, let's say, rectal cancer, we are accredited by the Commission on Cancer rectal program. So every single person diagnosed with rectal cancer coming here is going to have their case presented, has to have their case presented. And so if we're going to do chemotherapy and radiation therapy first, we present it before we start. Then after the chemotherapy and radiation therapy, we present it again before they may go to surgery. And then after the surgery, present it yet a third time. So that way we make sure that we're all coordinated in terms of the best care for that person to have. So they're getting 3 presentations just on one patient for one disease.
I know we can't get into any specifics of any patients, but are there any examples that come to mind of just how this sort of new process has positively impacted your patients?
I could tell you that I had a case where it was a lung cancer patient, and they were getting treated with immunotherapy, and they were progressing in one location. So I represented after they were progressing in just one location. So we all looked at it, and it was just everything. All the other disease was basically very, very calm. I'll say that, and no progression, just stable disease, and actually doing well, except for this one spot. So we debated what to do, whether change therapy, radiation therapy was a difficult place to radiate. So we talked to the pulmonologists who were in the room, and they said, you know what, I could reach that. I'll biopsy just that one spot. And when we biopsied, sure enough, actually, that patient had a mutation that they previously didn't have. And because of that, I was able to give the patient a pill rather than the immunotherapy and chemotherapy, and had a great response just to the pill.
And that's all because all those doctors are in
Got
the
in
same
the world,
room.
and we said, hey, let's try this. Let's do this first.
Can you also talk about how the Cancer Institute has helped to recruit really specialized, top-notch physicians who bring excellent cancer care to this community?
In our early discussions, we realized we really want to do that. And, one of the taglines we had, I hate to sound cliche, which is build it and they will come. So we knew if we started talking about things that we were trying to develop, the vision that we had for the Jellison Cancer Institute of being the best community oncology program in the nation, that would be very attractive to certain individuals. And we've been successful. We have attracted people from anywhere from the Harvard teaching hospitals to Hopkins to Toronto General, which is a great hospital, to Mayo Clinic, and just because of the thought of being part of what we're building here was very, very attractive for these individuals.
In many ways, the Cancer Institute is in its infancy, and it's continued to expand.
We got a long way to go, but we have a big plan.
So I'm asking if you can share a little bit about what's next for cancer care at Sarasota Memorial.
Well, we want to get the pavilion up and running. So that is going to be, the center place for outpatient cancer delivery around this area. We're going to be putting in more radiation oncology. We know we're going to be attracting more individuals who are going to practice that specialty. We have a couple more specialties that I don't want to talk about here that we want to bring into the area. And then our vision is that, as I said earlier, cancer care is hard. And the closer to home you can get it, the better off you are. So we want to spread it out further in the county and start having it easier for patients in South County to be treated, and also a little bit out east and to the north. So we want to spread it out. We also want to enable people to be able to have the possibility of participating in research trials. So we are building a building across the street, the Research and Education Institute. So we're hoping to be able to recruit individuals who are interested in providing research as well as accruing a lot of trials, so that offering that to our patients that, hey, I really want to be on a cutting edge of science. Do you have anything that will be appropriate for my malignancy? So that's part of our thinking, and also just making the experience a lot easier. So part of our plans is so that when you walk into the pavilion, so you're not just seeing one doctor, you're seeing all your doctors in that day. So it's going to be vertically integrated so that you can see the medical oncologist, the surgeon, and the radiation oncologist, and palliative care, and massage therapy or genetic counseling, whatever you need in one place, making a much easier experience on our patients. We're going to have a teaching kitchen in there because the best way of dealing with cancer is to prevent it or catch it early. So we want everyone to learn some healthy cooking techniques and what to do. So we're engaging the appropriate people for that, but it's going to be a real teaching kitchen for cooking.
You talked about cutting edge research. You talked about being on the forefront of cancer care. Sarasota Memorial is a public hospital. How important is it to have a cancer institute, to have a research and education institute based at a public hospital?
Well, I mean, I look at us and we're providing care to this community. And we have an older community that's getting larger by the day. Just looking at all the, building that's going on out there. So that we have responsibility to the citizens of Sarasota to make sure that they get the care they need. And everyone wants the best care they get, cancer care they can get, especially cancer care. I mean, it's because it scares everyone. They want to make sure that what they're getting is the cutting edge. So whether it's drugs or systemic therapy, whether it's radiation therapy, or whether it's surgical techniques in terms of robotics or just other technology that we need to employ, we want to meet those needs for this community. So fortunately, we are blessed with a hospital board that agrees with that. Administration has certainly been very, very positive in terms of promoting and growing the Cancer Institute. And also very, very most importantly, we have a hospital foundation that has supported everything we need in terms of providing those, whether it's research or whether it's technology. They have been really, really helpful in reaching our vision.
I know we could talk all day about exciting things happening at the Cancer Institute. Is there anything you want to leave the community with, or people listening or watching this podcast, when we talk about multidisciplinary tumor boards or the Cancer Institute?
We really, really, really want to be the place for this community to go to get cancer care. And we really think that when it's all said and done, it'll be a place that people will be very proud of and feel very, very comfortable coming here, knowing that they're going to get the best care they could get. And like I said, when it comes to cancer, people want, it's really scary. They want the best.
Dr. Brown, thank you so much for coming and talking to us about this today. As always, we encourage everyone in our community to visit smh.com to get the latest from Sarasota Memorial. Have a great day.